Attention chiropractors, slayers of subluxation, unleashers of the imprisoned impulse. I am Dr. Anthony Pellegrino from ChiroEdge, and welcome to this week's episode of the Chiropractic Research Breakdown, where each week we break down the most relevant chiropractic science and philosophy to empower you with the ammo and certainty necessary to change your community from the inside out. As always, the research that we get, we're going to be making into a newsletter, handed out in the office next week. So if you guys want to jump on that, you guys can get a free trial of that service at chiroedgemedia.com. Other than that, I am really excited because we have with us today Dr. Gary Wilkerson from the University of Tennessee at Chattanooga at the Graduate Athletic Training Program Office. Reading through his research, Dr. Wilkerson is an expert in all things, we'll say, neurological effects post-concussion, sports-related concussion, everything from heart rate variability, which you guys know on this show we talk about, well, pretty constantly because it's pretty important, to more recent papers on neuromechanical responsiveness. He's published with another chiropractor as well. So I am really excited to dive into the different studies we're going to be going through today. When I originally reached out to him, they had a case report that was published in the journal Sports called Daily Heart Rate Variability Before and After Concussion in an American College Football Player. As I'm sure you guys can imagine, I got really excited about that, emailed him, invited him onto the show, and I was really happy to immediately afterwards, when we were getting ready, and he starts sending me other stuff he's done as well that's relevant. Detection of persisting concussion effects on neuromechanical responsiveness that was published by the American College of Sports Medicine in 2018. Another paper that's in draft right now, Association of Concussion History with Neuromechanical Responsiveness Asymmetry. So I'm really excited to dive in here today. He's going to be giving us a lot of value, a lot of science, a lot of clinical application. So first off, Dr. Wilkerson, thank you so much for being on here with me. What we were just discussing before we pressed play was I kind of wanted to just get an idea before we dive into the really heady stuff. That case that we had discussed with the heart rate variability, the American college football player, if you can kind of just take us through this process, what happened, what baseline, what does it mean, everything like that. As much information as you want to give us, we're all ears.
Sure. Well, this particular case involved an elite Power 5 football player at a major university. And the key to, I think, what we were able to learn from this case study is the fact that we had daily measurements. Obviously, heart rate variability, when it's highly variable from day to day, it's an indication of unstable balance between sympathetic and parasympathetic output. So for this player, we had spring practice session, daily measurements immediately before practice sessions. And he demonstrated very stable day-to-day values. We also had measures leading up to the first full contact scrimmage through the first half of the month of August. And he sustained a concussion during that scrimmage, and we saw a rather profound increase in the day-to-day variability of those HRV measurements.
That's awesome. I really appreciate you kind of going through that with us, just giving us a little bit of a background on HRV. As we were kind of discussing in many chiropractic offices, we look at that just as an outcome measure to see how that, like you said, that balance between the parasympathetic and sympathetic nervous system is. And if we can improve that, obviously outcome changes, life changed, everything like that. In terms of doing as a baseline, obviously it's not like you guys were doing pre-post, like we're going to do HRV and then he's going to get a concussion and then we're going to do it afterwards and see how it changes. In a professional or highly elite type setting, what value does keeping baseline HRV measurements give you guys in the athletic training department?
Well, a number of universities will do regular HRV measurements primarily to monitor for overtraining, to determine if the intensity of the workouts is leading to an overtrained state, which will cause fluctuation in the HRV values. So it's an indicator of overtraining. This particular paper, the lead author was working on his PhD at this university at the time, Andrew Flatt. And Andrew, if you do a Google search on his name in Google Scholar, you're going to find that he's published many, many papers on heart rate variability. He's really more the expert than me on the techniques for getting reliable measures. But we kind of teamed up on this because my recent work has been concentrating a lot on how functional connectivity within and between brain networks is influencing functional capabilities.
That's amazing. And it looks like, just reading through these papers, the mechanism that you guys have really been exploring is like axonal degeneration in the brain, spatial separation in the brain, leading to, for example, I mean, just looking at this, I'm sure other things as well, decreased balance between the parasympathetic and the sympathetic nervous system, decreased neuromechanical responsiveness. Can you kind of take us through that mechanism a little bit more? I'd love to have a better understanding of it.
Sure. Well, let me do my best to break down an extremely complicated subject. The first point is that there is no single area of the brain that does one single thing. Every action that we perform is really the result of lots of information exchange that's going back and forth between nodes in the brain that are spatially separated from one another. And these nodes and edges that connect the nodes, or the pathways, the structural pathways, the white matter tracks that are connecting these different parts of the brain, have this synchronized, like an orchestra playing music, sheet music, that is, if it's finely tuned, then the performance can be very precise. So what we're seeing is that these different sets of networks function differently. You have a default mode network, which is basically active when you're daydreaming or when you're sleeping and you're not attending to any particular specific task. You then have the executive control network, which involves the dorsolateral prefrontal cortex and the posterior parietal cortex, that is performing these higher level cognitive functions. The default mode and the executive control networks normally are not activated at the same time. The default mode has to be shut down for the executive control to be turned on. And you have a salience network, which is centered on the anterior cingulate cortex, that flips the switch to turn off the default mode network, turn on the executive control network. So that's one simplistic explanation of kind of what's going on with this messaging that's going on between networks. There's also a great deal of specialization that differs between the right hemisphere of the brain and the left hemisphere of the brain. And what happens when a concussion is sustained is there's rarely any observable structural damage on MRI or on CAT scans. However, there are advanced neuroimaging techniques that are becoming available now, such as diffusion tensor imaging, that does allow visualization of where oxygen is being consumed along different pathways between these networks. So one of the things that's really interesting here is that the autonomic control network has interrelationships where there are reciprocal connections with this salience network. So what we find is that the speed of information processing, the efficiency of the actions that are produced by the coordinated messaging between these different nodes and between networks can get disrupted. Rather than seeing this macro structural damage, what we're actually seeing after concussions is a disruption in the ability of neurons to function normally with regard to their ability to transfer charged particles across the membrane, the exterior and the interior of the neuron. It's a neurometabolic disruption that is impeding the transmission of neural impulses in a normal manner. So what happens is these networks become functionally disconnected from one another, and the brain will begin to compensate for that by using different neural circuits rather than the one that's been impaired. And very often, those alternate neural circuits are not nearly as efficient. So we can see subtle alterations in the functional manifestation. The synchronization isn't what it normally would be, and so that can affect the ability to process information that's being perceived visually or kinesthetically. It's not being integrated as well, and then therefore the responses that are being produced to that input can be a little bit slower or asymmetrical between right and left sides of the body.
That's so fascinating. And I stayed, I think, mostly with you on that. It sounds like the way that you're almost describing this like functional disconnection, and I'm not sure how
Right.
familiar you are, is I've read papers that have used that same language, and it could just be this overarching, like trying to simplify it too much, but they've used that same language in a lot of the autonomic effects in like the autism spectrum disorder population.
Yes, there are similarities, and one of the things that's becoming really apparent to me is that we're going to improve the quality of the patient care that we deliver as we begin to move more and more toward the precision medicine concept, which really came out of cancer treatment, to consider the inner relationships that are occurring between lots of different systems, between the metabolism of substrate, the immune system's responses, the gut microbiome communication through the vagal nerve with the brain, the endocrine system, the HPA axis being activated, and then the emotional state. Because we see that people who have anxiety, people who have adverse reactions to stress, or who are depressed will have slower reaction times. There's an interruption in this neural processing, or at least slowing down of the processing. So, we're seeing similarities long-term degenerative problems in the brain resulting from sport-related concussions that are not unlike what we see in Parkinson's and Alzheimer's.
And I mean, that's just really fascinating. Another thing that I just noticed, and I think it was kind of remembering, I have them in front of me, so sorry if you hear some papers flipping. In the draft, I think it was the draft, in the introduction, every paper I've read from you, we specifically looked at sports-related concussion, which seems like a larger one-time injury. It looked like in one of these papers, we were also referencing repetitive, almost like micro traumas that were almost like soccer, like like heading a ball in soccer. Was I understanding that correctly or no?
Yes, you were. There is emerging evidence to indicate that relatively low-level head impacts can disrupt the blood-brain barrier. Now, the good news there is that barrier will become sealed again pretty quickly. It will repair itself. But here's this is largely theory, but there is evidence to support the idea that what is happening is that proteins that are normally contained within the brain and are not exposed to the circulating blood of the body can escape that blood-brain barrier. The immune system then begins to develop antibodies to that antigen. There's still not a problem as long as the blood-brain barrier is intact, but then you take another low-level impact, disrupt the blood-brain barrier temporarily again. Those antibodies can then pass through the blood-brain barrier and set up an autoimmune inflammatory response in the brain. And it appears that neurodegenerative conditions have that in common, that there is an autoimmune response that begins to cause degenerative changes in the white matter bundles that disrupt the functional connectivity between the different brain networks.
That's awesome. And I'm not sure what you just described is just really fascinating for me. I'm not sure if you're familiar with Dr. Raymond Damadian, who actually invented the upright MRI. If you're familiar with any of his research, we actually reviewed it on a podcast on this show, like maybe a year ago. And exactly what you had described, literally the exact same mechanism where he described that in the pathogenesis of multiple sclerosis. Right. I'll send you the paper after this if you're interested in it, where he was looking at craniocervical hemodynamics and looking at how pressure changes. Essentially, it was an early paper, so I'm not sure if the mechanism changed at all. If there's any changes that were causing this leaching of protein out of through the blood-brain barrier, which caused an autoimmune response to that, causing the degeneration from multiple sclerosis. What he also found was that, and this is kind of up your alley, was I think in the paper specifically that I'm referencing, in all of the individuals, he found on average that they all suffered a whiplash or concussion injury. I think it was on average of 7 to 8 years prior.
Right.
And he looked at craniocervical junction changes. And actually, and the reason I know the paper is because he recommended a chiropractor to come in and do a really specific adjustment at the atlas vertebra to restore the craniocervical junction, and saw huge symptomatic changes relatively quickly when restoring that proper hemodynamic flow. So it kind of sounds like, once again, those neurodegenerative things, it all comes together and we're starting to get a better understanding with that, thanks to work like what you're doing.
Yes, and it's extremely broad, because to really grasp these interrelationships that are occurring, it is as extreme as relationships are being established between the gut microbiome and leaky gut syndrome, allowing for the immune system to create an inflammatory response that can actually spread to the brain. And some people are much more susceptible to that to others because of their genetic makeup. So now, really, to be able to manage these things, I think we're going to have to begin to integrate information from genetics, from the environment that the person is exposed to, and their lifestyle factors have all got to be taken into consideration together. There are going to be individuals with single nucleotide polymorphisms that are going to be far more susceptible to this blood-brain barrier disruption and autoimmune inflammatory response than others, which is why it's so confusing to us as to why some athletes will develop chronic traumatic encephalopathy, horrible situation, and others seemingly are immune to it.
Yeah, absolutely. And I'm wondering, like, with that, if you've seen anything about, like, since we're talking about HRV, have you seen either research or just anecdotally with the work that you do, like, let's say if you look at 50 athletes and they all have concussion, or undergo a sports-related concussion, the individuals who going into that injury who have a lower heart rate variability maybe are more susceptible to having these symptomatic changes afterwards. Now, I'm just kind of throwing that out there. I don't know if that's something that's happened before.
That's not something that I can answer.
Okay.
But somewhat related to that, the thing you made me think of is that there is research out there among military personnel, in particular fighter pilots from other countries, not the United States Air Force, but researchers in some other countries have demonstrated that the most experienced fighter pilots have lower HRV values, and they're also much more capable of multitasking to, monitor their instruments, maneuver the aircraft, and, aim their guns. Whereas novice pilots demonstrate much higher HRV values and much greater variability in those values. So it appears that the ability to multitask and function very efficiently appears to relate to optimal control of the emotional and autonomic influences on our cognitive processing.
It makes sense if we can adapt and, not jump into a sympathetic state, not think that there's a bear in the plane with us,
Right.
we're going to perform better. I wanted to cycle back around really quickly. You mentioned the precision medicine concept, and I'm really unfamiliar with that. It seemed as though you were referencing that we're kind of taking a step back and looking at almost like a more holistic, looking at the person as a whole versus just staying super specialized within each individual system, not having them talk to one another. Can you kind of go a little bit more into that?
Sure. The idea there is, as I said, this has largely been driven by the oncologists. The cancer prevention and treatment has become very, very precise in developing individualized treatment plans. And I think that's where we've got to go generally in medical care. I think we've got to begin to look a little bit more broadly at, like, for example, in my field, I spent the first half of my career primarily doing ACL reconstruction, rehabilitation, and treating patients with chronic ankle instability. So I was very orthopedically oriented. And for decades, what we've done in that area has been so focused on mechanical considerations. Is the ligament intact, or is there evidence of laxity in the ligament that's rendering the joint mechanically unstable? Are they strong, or do they have evidence of muscle weakness and imbalances between the dominant and non-dominant extremities, or between the quadriceps and the hamstrings? Do they have good joint range of motion? Are there any restrictions to motion? It's all been very peripheral and very mechanically oriented. What is emerging very, very clearly to me is that we are neglecting the neurocognitive component we rely so much on our visual input, coordination with afferents from the vestibular apparatus that's being integrated in a way that allows some athletes to be very neuromechanically responsive. They have good balance, they have fast reaction time, they have good peripheral vision. And then we have other athletes, either because of joint injuries or mild traumatic brain injuries, have very, very subtle disruptions in the brain's neural circuitry that's affecting their processing and is rendering them more susceptible to not responding appropriately to events that are occurring in their chaotic environment that they're exposed to when a 300-pound defensive end is coming trying to take your head off at the same time that you're trying to decide which direction to run with the ball.
There's a reason. That's the only reason I don't play football. It has nothing to do with skill or size or anything like that. It's just the lineman coming at me and sympathetic, parasympathetic balance. So 100%. I'm just so intrigued by everything that we were just kind of talking about. This neuromechanical responsiveness. I got two other studies that we're looking at. We kind of talked about heart rate variability and how that could change. I would love to just have a better understanding of what these changes in neuromechanical responsiveness actually are from like a clinical standpoint.
Well, one of the tests that we use a lot that some folks may be familiar with, they may have heard of this before, is called the Erickson flanker test. That is a series of 5 arrows that look like the greater than or less than signs on your computer keyboard. And we present a row of 5 of those that either all point right or all point left, or we give you a series where the center arrow points a direction different from the 2 flanking arrows, which requires you to resolve that conflict, to be able to tell which direction is the center arrow point. That takes a little bit of time. And what we find is that people with a history of concussion or less than optimal neuromechanical responses, we mean converting the visual input, the cognitive processing of that visual input, and then the generation of the appropriate muscle responses is prolonged. So we can look at how, if we give you a simultaneous cognitive task to pick up visual stimuli while your body is moving, while you're translocating your body mass, we find that superimposed cognitive task can reveal subtle abnormalities in your ability to move.
And do we think that these abnormalities that are happening in terms of movement are happening due to aberrant afferent signals, improper efferent signals? Do we not know?
Well, it depends on the cause. See, I'm kind of working at it from both directions. As I said, most of my career has been spent working with lower extremity injuries, and my primary expertise is really in lower extremity biomechanics. But I began to move into the neurocognitive realm because I saw how important it was to actually controlling the mechanical forces that are being generated in the extremities. But to give you an example, I have a colleague, Dustin Grooms, who's at Ohio University. He's also an athletic trainer, his primary area of interest is the ACL tear in the knee, because when the ACL is torn, there are mechanoreceptors in that ligament that are normally sending afferent signals about inertial changes in the knee. And when the brain no longer gets those signals, it has to compensate somehow. So what it begins to do is rely more on vision, which sounds like a good thing, except that when you surgically reconstruct that ACL, the new graft doesn't have those nerve endings to pick up and send those inertial signals. So we can rehabilitate somebody in a clinical setting and everything is looking good. But then as soon as we send them back onto the basketball court or the soccer field or the football field, 20 to 30% of them will rupture that ACL graft or the ACL of the other extremity. So what's happening is we've compensated with visual input, but we're using up all of our reserve cognitive capacity with our vision such that we can't adapt to the chaotic visual scene that is surrounding you in the real situation. So it could be a tear of the ACL or a tear of the anterior talofibular ligament in the ankle that is disrupting brain processing because of a lack of the afferent input. It could be head impacts that are having very, very subtle effects on the neurometabolic processes that the neurons carry out, and it's slowing down the conduction velocities of the neural impulses between the nodes of the networks.
Yeah, and just to kind of bring it full circle for the audience and those who are watching, chiropractors, it makes so much sense that what we're talking about is essentially proprioception of the knee and ankle, and how improper proprioception is going to cause this, maybe not necessarily an overload, but make the brain work harder in other areas, essentially, because it's not getting the right information.
Yeah, the simple analogy that I usually relate to my students is I encourage them to think about the structural connections between the networks as like interstates and secondary roads, city streets with stop signs and traffic signals. If you're on a freeway and the traffic is all moving at 80 miles an hour, but everybody's going 80 miles an hour, everything keeps moving. But all it takes is one fender bender for everything to come to a stop. So it may not be a lot of damage. It may not have been a big accident, but it has this profound effect on the flow of the traffic. So what do? You start looking for an exit ramp to get off and take an alternate route, but it's going to take you longer on that alternate route because you got to deal with all the other people who are getting off on that exit and the stop signs and the traffic signals. It's going to take you longer to get there, but it's better than sitting there where the traffic's not moving. That's kind of what the brain's doing. It will alter your route, like your GPS rerouting. And then once you get accustomed to that new route, there's a tendency not to go back to the older one that's faster and more efficient once it's available.
Yeah, it makes a lot of sense for us, especially when we look at, for example, in chiropractic, there's huge focus in types of practices for people who watch this, a huge focus on the structure and alignment of the upper cervical area, which has, some of the highest densities of muscle spindles in the entire body. And by properly restoring the alignment, restoring proper, essentially tension to, let's say, the musculature up there, we can look at other things, but we'll just stay really simple with muscle spindles. By restoring proper afferent information up to the brain, just reducing the amount of off-ramps that we got to take and actually just processing. Just going to have autonomic indications, just like we were talking about, autonomic, emotional, all these different implications that it can have. And yes, we obviously need more research on this topic, but it's just so amazing to see how the same work that you're doing and what we see clinically and every day, how much interplay there is there. And that's why I was so excited to have you on here. This has been pretty cool.
Yeah, the interrelationships are the key to getting a handle on this because as you talk about the cervical spine, really, really common that we see cervical strain of the muscles along with the concussion because of the impact of the head is also imposing a load on the C-spine. Again, the interconnectedness, we clearly see changes in emotions and psychosocial responses that are different after the concussions occur, which is an indication that in some way those signals are being disrupted in the way that they would normally be transmitting between the different nodes of the networks.
Yeah, love it. Well, I want to thank you so much for coming on here with me. I got a lot of value out of this. Doc, if you saw me looking down at all, I wasn't being rude. I was actually taking notes. I was actually taking notes because this has been really great. I have some other things that I want to read now based on this conversation, really to dive deeper into these topics. I just wanted to ask you, is there anything that maybe you think I missed? Any other message you want to kind of get across? Anything that you want to add that maybe we haven't discussed yet?
Well, we don't have the evidence right now to be able to make any real strong statements about this, but I'm encouraged by what appears to be a tremendous capacity of the brain for neuroplasticity to basically repair itself and to alter in ways that it does function more efficiently. So I'm pretty optimistic that over time we're going to begin to learn how to construct our interventions, whether they be therapeutic exercise or whether they be pharmaceutical or whether they be manipulation or whatever it is. I think we're going to get better at figuring out how to facilitate adaptations that improve the neural circuitry.
Absolutely. And working together is going to be a huge piece of that. Dr. Wilkerson, I think that in another life, if you do come back, I think you're going to be a chiropractor. I think that's what's going to happen. Your adaptability, neuroplasticity, if you could listen to what my dreams at night are made of, it's those words. So thank you for using them. It's been awesome. Well, I wanted to thank you so much for coming on here. I got a lot of value from this. I hope that we continue to be in conversations in the future. If you are ever looking for other chiropractic researchers to work with or anything like that, please let me know, and I can put you in contact with anybody in your area. I should know lots of good chiropractors who are close to the University of Tennessee at Chattanooga, so I can always put you guys in contact. So I just wanted to thank you so much for being on here. I hope that you have, thank you so much for sharing. I hope you have an amazing day, an amazing week. And for those of you guys who are listening, you're probably going to want to go back and listen to this episode a couple times. I know that I'm going to. There's so much value in there that just kind of listening the first time, I was almost looking back a little bit, and the brain circuitry is so fascinating to us, and it has such a huge clinical implication for what we do every day and the changes that we see in our office. So please go back and listen to this. I know I am. And guys, if you guys are listening, go out there, slay some subluxations. I love you all, and have a great week.